So today we are going to discuss bleeding disorders. Now bleeding disorders will come as a short note or long answers. So when you're going to write bleeding disorders, remember you have to write in two-way form, that it can be because of the platelet dysfunction, or it can be because of the coagulation disorder, right? So when you write under the platelet dysfunction, you write ITP, Idiopathic Thrombocytopenic Purpura, then Thrombotic Thrombocytopenic Purpura, TTP, and you can write von Willebrand's disease, and you can write HUS, Hemolytic Uremic syndrome. Under the coagulation disorder, you write DIC, which is also very rare, and you can write hemophilia also, hemophilia A and B. So we will not go into details in every, but we will discuss DIC today in very details, and let's have an overview of what are these idiopathic thrombocytopenic, thrombotic thrombocytopenic purpura, von Willebrand disease, and hemolytic uremic syndrome. So we start first with idiopathic thrombocytopenic purpura. Now, as the name suggests, it is idiopathic. This condition is idiopathic. So idiopathic means platelet count is low. Remember, normal platelet count is 150,000 to 400,000. Okay, that is normal platelet count is 150 to 400,000. So platelet count is low, and bone marrow status is normal. So we say this is idiopathic because the cause is unknown. So many times in children, they suddenly have spontaneous bleeding from nose, gums, okay, and we don't find any cause. Then we put them in the term of idiopathic thrombocytopenic purpura. Okay, idiopathic thrombocytopenic, as the name suggests, thrombocytopenic means low platelet count, but the bone marrow status is normal, and it occurs mostly in children, and it is acute conditions most of the times. And remember, it usually resolves within 2 to 3 months. In adults, it resolves within 6 months, and in children, it usually resolves within 2 to 3 months. So this is in short about ITP. Now, one more thing about ITP, that we need to know that what is the pathophysiology of ITP, that most 50% of cases, though yes, we don't know the exact cause, but in 50% of cases, there is antibodies directed against platelets. Means the platelets are coated with IgG antibodies. They are coated with IgG antibodies. So when the platelets are coated with IgG antibodies, they are vulnerable for opsonization. As a result, there will be opsonization, and they are attacked by the splenic macrophages, and they break down, and there is low platelet count. So this is the main pathophysiology, but we don't know why there is. So that's why we call it idiopathic. Okay. So next, let's move to the next one, that is thrombotic thrombocytopenic purpura. So next is thrombotic thrombocytopenic purpura. So 50% of cases here are genetic, where there is deficient of one gene which encodes for one protein, ADAMTS13. Okay, 50% cases are because of this genetic deficient, and 50% cases are because of antibodies directed against it. So 50% are because of antibodies directed against it, and 50% are genetically deficient. But the main problem is when there is a defective ADAMTS13. Now, what is this ADAMTS13? Remember, this ADAMTS13, it is a degrading mechanism for the von Willebrand factor. Okay, let me explain like this. So this is the blood vessels. So in a blood vessels, we know there is von Willebrand factor. Okay. These are the von Willebrand factor. So von Willebrand factor is the mediating mechanism for adherence of platelets to the endothelium, right? So these von Willebrand factors, when they are attached to the endothelium, exposed endothelium, when they are attached, then these are degraded, they are being cleared, they are being broken down They are being broken down by whom? They are being broken down by this ADAM-TS13. Now, if there is genetically deficient or if there is defective ADAM-TS13 or if there is antibodies are attacking this and their numbers are down, what happens is bone Wilson factor, they cannot be cleared up. They could not be degraded. As a result, their numbers are increased because of lack of clearance. So you can see the von Willebrand factor has accumulated here because they are not being cleared in time to time. So when they are not being cleared in time to time, you see what they are doing. They are accumulating here, and what they are doing, you can see that one von Willebrand factor is there. What will happen next? Come with the platelets. So there will be formation of microclots everywhere. Widespread formation of microclots, which can lead to ischemic-like symptoms. Okay, so here there is two things. That because of the microclots, what will happen? There will be ischemic-like symptoms in the distal area. There will be ischemic-like symptoms. Plus what? Plus there will be platelets are coming. So ultimately there is consumption of platelets also. As a result, platelet count can go down and it can lead to serious bleeding. So this is another thing that can happen with thrombotic thrombocytopenic purpura. Okay, thrombotic thrombocytopenic purpura. The clinical features in thrombotic thrombocytopenic purpura, there are basically 5 clinical symptoms. First, we have to remember this is the mnemonic ART. ART means there is a signs and symptoms of anemia. Okay, R for renal failure. Then 3 for thrombocytopenia, which is decreased number of platelets. Plus, there will be fever and neurological signs like headaches, seizures, all the neurological signs. So these are the basically clinically 5 things that are found in relation to thrombotic thrombocytopenic purpura. So next we go for, and one more thing related here. Now what happens here? So you have to see that these are now. So one more thing that I'm trying to, that when you will get a question, you will get a lot of questions in thrombotic thrombocytopenic purpura, and in MCQs you see that there is finding of cystocytes. Cystocytes. Now what are these cystocytes? Okay, so you have to know that when a RBC is broken down or a fragmented RBC, let's just say this is a RBC and it has been broken down, then they can be jagged RBCs. Usually there is 2 pointed ends, broken RBCs, fragmented RBCs with 2 pointed ends. They are called cystocytes. Basically they are broken down bits and bits pieces of RBCs. So these are usually a pathological finding in cases of thrombotic thrombocytopenic purpura. Now why is this happening? Now we know that there is less clearance, so there is microscopic clots here. So as a result, you can see when there is, suppose this is, so let's say in the small blood vessels there are some clots here, there are some clots here. Okay, there are some clots along with because of collection of von Willebrand factor and plus platelets is forming a clot. Then when in the small vessels RBCs are trying to escape, they are during this shear force and during the strong current of the blood, during this passing through the small space, these RBCs are broken down into fragments. They are broken down into fragments with 2 pointed ends. These are called cystocytes. Okay, these are one of the clinical finding, one of the laboratory finding. Sorry, not clinical finding. These are one of the laboratory finding in thrombotic thrombocytopenic purpura. Then in other things, apart from that, number 3 is very oftenly coming in MCQs most of the time. There is hemolytic uremic syndrome, HUS, hemolytic uremic syndrome. So remember, hemolytic uremic syndrome is a condition when there is bloody diarrhea. It's mostly found in children. There is bloody diarrhea, and it is caused by Shiga-like toxin. Shiga-like toxins, not Shigella. Remember, Shiga-like toxins of E. coli. Shiga-like toxin of E. coli. The most common strain of E. coli that causes HUS is 0157 H7. 0157H7. This is the strain of E. coli that causes bloody diarrhea, and along with that, same things, ART is found, anemia-like symptoms, anemia like findings, renal failure, that is kidneys are affected, renal failure and thrombocytopenia. So these are found in HUS, hemolytic uremic syndrome, right? Then after this, in platelet disorders, we have von Willebrand disease, where there is deficient of von Willebrand factor. Okay, there is von Willebrand disease, where there is deficient of von Willebrand factor. Then number 5, there can be Bernard-Soulier syndrome. Now in Bernard-Soulier syndrome, what happens in the platelets? We know the platelets are coated with one receptor called glycoprotein 2A. Okay, so glycoprotein 2A receptor is deficient. So as a result, they cannot be adhered. So when this receptor is deficient, then these platelets cannot be adhered to the endothelium, to the von Willebrand factor, and finally it causes bleeding disorders. So these bleeding disorders are what we discussed till now. They are related to platelet dysfunctions. Next, very importantly, in the clotting disorders. Now bleeding disorder due to clotting factors. So before going to the clotting factors, let me explain you what is DIC. Disseminated intravascular coagulation, DIC, disseminated intravascular coagulation. The basic mechanism of DIC is that there is consumption, all these clotting factors. Now remember, we have two type of clotting mechanism, extrinsic and intrinsic. Intrinsic starts with factor 12. Okay, so prothrombin to thrombin, and finally thrombin converts fibrinogen to fibrin. We know that from our year 1 that it produces fibrin. Okay, so this is the intrinsic mechanism. Another mechanism in extrinsic mechanism is that there is a tissue factor which combines with factor 7, and they usually stimulate this directly. Factor converts 10 to 10A, and prothrombin is converted to thrombin, and finally fibrinogen is converted to fibrin. Okay, so this is the extrinsic mechanism. Now what happens in DIC? Remember, DIC, there is the basic pathology of DIC is there is widespread endothelial damage. First thing. And next thing, there is release of tissue factors. Now when this endothelial is damaged, now let's see what is the endothelium. Endothelium, we know in the blood vessels there is endothelium. Right? There is endothelium. Now what is below the endothelium? Below the endothelium we call it, this is subendothelium. What is present in the subendothelium? The present in the subendothelium is tissue factors. Here there is tissue factors are produced. Okay, these are tissue factors. So tissue factors are present here. So the moment when endothelium is damaged, it can be damaged because of bacterial endotoxins. It can be damaged because of massive trauma, burns, surgery. Okay, so when the subendothelial deposits, means the tissue factors are exposed, they leak into the blood, then they can combine with factor 7. They have a high affinity to factor 7. So when this tissue factor is combined with factor 7 and they form a complex, then they can convert this factor 10 to 10A and convert prothrombin to thrombin, and ultimately stimulating the coagulation mechanism, ultimately formation of fibrin. And the whole coagulation mechanism is being stimulated. Now what happens when the coagulation mechanism is suddenly stimulated? It will consume all the clotting factors. Clotting factors are very fastly consumed, and as a result our body becomes deficient of clotting factors, and as a result there is a bleeding mechanism, which is bleeding is started, spontaneous bleeding will start because of this consumption of this clotting factor. That's why it's also called as consumption coagulopathy. So there is endothelial damage, there is release of tissue factor, And there is also release of thromboplastin. Now let me tell you, thromboplastin is different from tissue factor. In earlier books it is mentioned as the same, that tissue factor and thromboplastin is same. So thromboplastin means tissue factor plus phospholipid. Now phospholipids are also damaged, are also released by the damaged tissues. When the tissues are damaged, they also release phospholipid. So any sort of tissue damage can release phospholipids, which can combine with tissue factor, and this ultimately this tissue factor can come with factor 7 and stimulate the whole direct pathway. Okay. When we remove the phospholipids, or when we remove the tissue factor, then here this is phospholipids. Phospholipids can stimulate directly the indirect pathway also. Can stimulate this intrinsic mechanism also. Okay. This is intrinsic, this is extrinsic. So phospholipids can stimulate this indirect pathway, can activate this factor 12. So when we analyze the phospholipids, then we are talking about partial thromboplastin time. And when we are talking about the thromboplastin that is stimulating this pathway, we are talking about actually complete thromboplastin time. Okay. So whenever there is any white endothelial damage because of the exposure of this tissue factor escaping into the blood, it can combine with factor 7 and cause making of fibrin. And then tissue factors can be also released by monocytes. It can, because tissue factors are not only present here, they are also present in leukocytes, especially in monocytes. So any sort of like inflammation process, let me say gram negative endotoxins like meningococcemia. Okay, so when there is endotoxins are liberated, then they can, what they will stimulate? They will stimulate the release of interleukins 1 and tumor necrosis factor alpha. Okay, by monocytes. So during when there is interaction of these endotoxins with monocytes, there will be release of plenty of tissue factor. That is one thing. But and plus this TNF factor alpha, tumor necrosis factor alpha, also plays a big important role in cases of DIC caused by shock. It caused by DIC caused by shock, it plays a big important role, TNF. So overall what happens, there is formation of tissue factor. So this tissue factor can combine with 7 and stimulate the whole coagulation factor. But if the DIC is because of obstetric complications, like, so what obstetric complications we are talking about? Obstetric complications are retained placenta, dead fetus, abruptio placenta, retained placenta, dead fetus, abruptio placenta. So there is escaping of tissue factors here. Here because of tissue factors escaping into the blood and cause DIC. So in cases of DIC, because of obstetric complication, there is it's not that there is endothelial damage. It's because the escaping of tissue factor to the blood is and causing DIC. So what are the consequences of DIC? So first thing is that in DIC there is all the platelet factors are consumed. All the there is platelets and clotting factors are consumed. So there will be bleeding. There will be bleeding problems. There will be bleeding disorders because clotting factors are consumed. Next, because of the formation of clot, there will be formation of clot. So there will be formation of clot. So because of the formation of clot, there will be ischemic like symptoms, ischemia like symptoms, like anemia like symptoms. So there will be bleeding disorders and also simultaneously there is formation of clot because of the rapid stimulation of the clotting factor, stimulation of the clotting cascade pathway, and there are lots of clot which can lead to microangiopathic and can lead to ischemic like symptoms, infarction like symptoms, and also there is bleeding. So this is a condition of nightmare, you can say, for any physician, where there is bleeding and there is formation of clot, means thrombosis and bleeding both at the same time. Okay, so what are the most common causes of DIC? So one is obstetric like symptoms, obstetrics complications. Remember, DIC is not a primary disease. DIC is always a secondary disease. You have to keep that in mind. Okay, obstetric complications like retained placenta, dead fetus, abruptio placenta, then any cases of massive trauma, surgery, burns, they can also give rise to DIC. Then infections like meningococcemia, rickettsia, okay, even viral infections. Most common is gram-negative endotoxins are really responsible for DIC. Other causes, snake bite, some drugs like amphetamines, it often comes in questions. That name one drug causing DIC. Amphetamines is responsible for bleeding disorders. And what else can be other causes? There is also, don't forget, leukemia and promyelocytic leukemia, neoplasms. Okay, promyelocytic leukemia is also one cause. So these are the basic things related to DIC. So remember, when there is DIC, there is spontaneous bleeding plus there is thrombosis also. So you have to keep that in mind. So that's why the treatment is very difficult. Okay. So in DIC, remember, another thing to be noted, it often asks in the exam because of the fibrin, continuous formation of fibrin. Now fibrin is also, there is fibrinolytic mechanism in the body that will break down the fibrin. So when fibrin will be broken down, okay, then it can form D dimers. So this D dimers level goes very high, which is one diagnostic point in DIC. There will be high amount of D dimer. And in relation to the other causes like platelet, TTP, thrombocytic purpura, ITP, idiopathic thrombocytopenic. So what is the difference here? In lab, you will find the fibrinogen level is down. Okay. Yes, it is bleeding time, clotting time will be very high. Plus there will be increased D dimer. So that's an important diagnostic points here. Okay, so these are the few things related to DIC in relation to bleeding disorders. Apart from DIC, there is also another type of bleeding disorder due to clotting pathways disorders are hemophilia type A and B, which are due to deficiency of factor 8 and factor 9. Okay, so this is about, in short, about bleeding disorders. Thank you.